This is the thymus, the primary training academy for your immune system. It is responsible for building your long-term defense against infections and viruses. But as you watch, this organ is rapidly replacing its active cellular network with inert, yellow, fatty tissue. This structural collapse is known as involution. Whether triggered by the natural aging process or acute stressors like chemotherapy, the thymus degrades. The very tissue required to keep you safe simply shuts down and turns to fat. To reverse this, we need a precise plan. We are going to build a 4-step clinical blueprint to naturally regenerate damaged thymic tissue using targeted hormonal therapies. Understanding and reversing this atrophy is a requirement for long-term health. If we only manage short-term symptoms, we ignore the underlying cause of immune failure. Rebuilding the thymus ensures the body can maintain its own baseline defense for decades. Step 1. Identifying what breaks during involution. The foundation of the thymus is the thymic epithelial cell, or TEC. These cells are the architects that physically guide every stage of T-cell development. First, a progenitor cell enters the cortex for positive selection, testing its ability to recognize foreign antigens. Next, MTECs execute negative selection, destroying any T cells that would attack the host. During involution, these critical regions shrink, dropping surviving T cell output to 0. When this pipeline fails, the body loses its baseline immunity. It can no longer produce the new, naive T cells needed to identify unfamiliar threats. This is why an effective protocol must specifically rebuild the TEC infrastructure. Simply adding random immune cells to the blood ignores the fact that the training academy itself has collapsed. Step 2 initiates the repair. To start the regeneration process, we use growth hormone, or GH, as our primary catalyst. A signal from the pituitary gland releases GH, triggering localized production of insulin-like growth factor 1 within the thymus. Zooming in, IGF-1 binds directly to TEC receptors, stimulating rapid cellular multiplication. This restores structural density, repairing the architecture lost during involution. As the TEC density returns, the maturation and migration of new T cells begin to accelerate. The assembly line is back online. The benchmark for success in Step 2 is a measurable, sustained increase in total thymocyte numbers within the organ. By activating this specific hormonal circuit, we have reversed the structural decline, turning a dormant production center back into an active one. Step 3 is about sustainability. If we only push the GH pathway, the system can eventually stall. We have to fine-tune the somatotropic axis using accelerators and inhibitors. Ghrelin is our primary accelerator. As a GH secretagogue, it ensures the growth hormone release is both forced and sustained over time. Ghrelin stops existing TECs from transitioning into fat. As these fatty deposits melt away, they reveal the dense network of active epithelial cells underneath. However, the body also produces an opposing force, somatostatin. While ghrelin pushes a dial up to drive epithelial cell division, somatostatin pushes a dial down. High levels of somatostatin halt the regenerative process. To maintain growth, we must lock the somatostatin dial at 0, allowing the GH pathway to operate without resistance. This dual-action approach, combining positive stimulation with inhibitor suppression, is what allows us to successfully rescue the thymic microenvironment. Step 4 moves from protocol design into real-world tracking. We need to see if these structural changes lead to better health outcomes. Because the GH axis affects the whole body, successful human trials have often paired growth hormone with metformin and DHEA. These cofactors help manage the hormonal load, and this combined approach has successfully induced thymus regeneration in healthy aged participants. We see similar results in HIV-positive patients. During treatment, the use of these hormonal pathways has led to a measurable return of naive T-cell output, even after significant prior damage. This rejuvenated tissue provides a concrete advantage. Data shows that a recovered thymus provides a stronger defense against severe pathogens, including the Salmonella bacteria, the herpes virus, and the COVID-19 virus, compared to an involuted one. We track 3 metrics to confirm this works: increased thymus volume, a higher naive T-cell count, and a measurable decrease in overall infection rates. These clinical endpoints confirm that the intervention restores the actual machinery of the immune system. We are seeing functional immunity that saves lives. We have successfully completed the 4-step blueprint for thymic regeneration. The sequence is clear. We assess the atrophy, activate the GH axis, tune the somatotropic signals, and monitor the clinical results. Researchers and clinical advocates can now apply this framework to their own studies. You can download the full protocol cheat sheet linked below to see the specific dosages and timing used in these trials. Mastering this blueprint moves the thymus from a state of guaranteed decay into a functional organ capable of supporting long-term survival.